Well, hey, good morning, everybody. Thank you for joining this panel. As a reminder, the panel that you've joined is a discussion around the pandemic, health disparities, and lessons we've relearned about ourselves. And so I'm honored to be a part of this. My name is Bill Ames. I'm the Executive Healthcare Director for Genentech. I'm joined on the panel by Amick Sinclair, Zeke Smith, and Senator Emily Randall. I thought what we would do today is really start off by sort of going around the horn here and telling you all a little bit about us, what we do, and specific to this topic, what the organizations we represent or the functions that we serve, what we're working on. Take a few minutes to do that each, and then really dive into either questions that come in the chat. And as a reminder, please enter your questions in the chat, and we'll take those on, or we'll go through a dialogue on our own, and really looking forward to that discussion. But I guess I'll go ahead and get it started with who I am. So as I said, my name is Bill Ames. I do work for Genentech. It's a biopharmaceutical organization who's been in existence for about 45 years. And what I wanted to share related to this topic regarding Genentech is, the pharmaceutical industry obviously has a well-deserved stigma attached to it in terms of some of the work that's been done over the years. And it's been something that we've really tried to overcome. And specific to Genentech here over the last couple of years, we've really had an awakening in terms of how we are representing or being represented in the local communities. Much of the time, what happens in our industry is we have national strategies, and then we kick those out to the local communities and try to, paint that national strategy to the local community. And, that's worked for years and years and years. But now that we're in sort of, in 2021, and we've known this for some time, we found that's pretty ineffective, and it doesn't translate well to what, patients need and what providers need. And so, we sort of took the hard decision here a couple of years ago to really reshape ourselves and to think about our business from the ground up. And so we restructured. I, for instance, took a position here in the Spokane area, an area that I was born and raised in, very connected to. And along with serving Eastern Washington, I also cover the states of Idaho and Montana, really trying to look at what are the needs of our communities here, and then roll those up to the broader organization and gain support from them in terms of what's best for us. And we're still very new at it. We're learning, but we're excited about some of the early returns on how we're able to serve the community. And it includes opportunities like this to join this awesome panel and talk to all of you. Specific to this topic, one of the things that, as you think about disparities in care, there are many different, platforms around this. You have socioeconomic, you have race, you have gender. And here in our area, obviously, we're much more, much more of a rural community, different, say, perhaps than from Seattle or some of the larger cities. And so what we're really doing is we're looking at what can we do locally to best serve the needs of the people in Eastern Washington. And I'm in the great position of being able to have a decision-making authority around what our organization is doing to support this. And so we're doing a lot of work with the WHA, other patient advocacy associations, to first of all really understand what the needs of the community are, and then try to tackle those one by one with the team that I have. And whether it's cancer screening, inclusive research is an area that we're really focused on, making sure that one of the commitments that we have at Genentech is to really make sure that instead of going out to these major institutions when we're trying to answer questions around different pharmaceuticals and what the effect might be, really starting in the community, starting with populations that are underserved, and being able to answer questions that are going to be meaningful to that population. So that's what's exciting for us. Again, we're still learning, it's still very new for us. but we feel like it's the right thing to do, and we're excited about the future ahead in terms of this particular topic and what Genentech can bring to it. So I'm going to now transition it over to Kaimi. How about we go to you for a little bit about yourself and what you all are doing at WSU?
Sure. So my name is Amick Sinclair. I am Cherokee, but I've grown up all over this country. And I am an associate professor at Washington State University. And I am located in the Institute for Research and Education to Advance Community Health. We call it iReach. And we're located in Seattle, Washington. And our group does community engaged research across the country with American Indians, Alaska Natives, and Native Hawaiians and Pacific Islanders. And I'm not sure if you all know this, but Washington has the third largest population of Native Hawaiians and Pacific Islanders after Hawaii and California. And so in 2012, I moved here from Hawaii, where I'd worked at the university there in the Department of Native Hawaiian Health. And when I came here, I started connecting with Native Hawaiian Pacific Islander serving organizations and found that nobody was doing any research that included those groups. And then as we saw, as a result, of COVID, the Marshallese community in particular was hit very hard by COVID. So in Spokane County, the Marshallese are about 1% of the population, but experienced 30% of the COVID cases between March and May of 2020. So we've spent a lot of time working with the Native Hawaiian Pacific Islander communities here in Washington, and currently have a National Institutes of Health funded grant to address COVID-19 surveillance activities in the Native Hawaiian and Pacific Islander communities, and specifically with Marshallese, both here on the west side of the state and on the east side in Spokane. So we're really excited about that opportunity to work with these communities to include them in research and to do it in a way that engages them. And it's participatory surveillance. So it's like community engaged, but it's participatory surveillance. So it's really exciting to identify ways that, and culturally appropriate ways that will contribute to what we know about the spread of COVID-19 and can, help us in future pandemics, if there are any. Unfortunately, there may be, but we're hoping not. But we also do a lot of work in, I do a lot of diabetes self-management education, hypertension management education. So all of those cardiometabolic disparities with American Indians and Native Hawaiians and Pacific Islanders, as I mentioned, across the country, and of course here in Washington too. So I'm really excited to be here and look forward to our conversation. Thank you so much.
Yeah, thanks, Kaimi. Very, very interesting, and look forward to more discussion around this as we continue the panel. Zeke, you want to go next?
I do, as long as I get my mic on, which I think I did. So thanks, Bill. Pleasure to be here. My name is Zeke Smith, and I'm the president at the Empire Health Foundation, which is located in the Inland Northwest, specifically in Spokane. I have been here for just under a year. And by here, I mean both at the Empire Health Foundation and in Washington, in the Spokane area. Spent about 30 years before that working in Portland, Oregon. So I'm not new to the Pacific Northwest, but new to the East Side and to this work here at the Empire Health Foundation. The Empire Health Foundation is about 12 years old. It's a health conversion fund, which means that when Deaconess and Valley hospitals were sold in 2008 to Community Health Services, which was a for-profit organization. Before that, the hospitals had been nonprofit. In that kind of a sale of a health system like that to a for-profit organization, the proceeds from that still need to be available for public benefit. And so in this case, and in many others, but in this case, Empire Health Foundation was established with those initial proceeds from that sale to continue to provide health-related benefit in the region. We consider our region the 7 counties in the northeast corner of the state. So Ponderay, Stevens, Ferry, Spokane, Lincoln, Whitman, and Adams counties. And we also consider the 3 tribal nations in our community, the Kalispel, the Spokane, and the Colville Confederated Tribes, their lands and their regions as a part of the communities that we serve in this region. Our mission is specifically focused on health equity and on increasing and improving health equity across our region. And over the course of the first 10 years of time, the foundation has focused those efforts a lot around care coordination, really focusing in on what it means to be supporting communities and to be supporting the individuals and families and populations that are most affected by health inequities in productive ways that our systems aren't necessarily well designed for. And so how to make those connections between community and system. We've done quite a bit of work around trying to ensure that we have the right mix and match of workforce in our region to be able to address needs. So that means partnering with institutions like Washington State University, particularly focused on how we can develop pathways for Native American and Indigenous students to join the healthcare workforce as doctors and as other professionals in the system, as well as thinking about how folks from other backgrounds are prepared to work in and with both tribal communities and Native communities that are not on the reservations. As one example, but we've also, again, extended that work around care coordination and the kinds of individuals that are best suited to really meet the needs of individuals that the systems haven't met their needs effectively in the past. And then we also have focused on family preservation, really recognizing the importance of supporting strong families and supporting their ability to be together. So that means we've worked to support kids who are in different systems, foster care or otherwise, to get back to and be back with their families as quickly as makes sense, and then really working on the kinds of supports to ensure that those families are in a position to support the kids in their families effectively. So those are just a few of the areas that we've been working on. Because I'm new in this role, I followed a founder president before. We have quite a few board members that are really new as well. We're really in the process of thinking about and looking at what the next phase of our work needs to be and how we really take some of the approaches that have been successful and have been important in how we've done our work in the past, but also create space for what it looks like to do the work differently moving forward. And to Bill's point about Genentech, that for us, that's a lot about really engaging directly in community and with community as we move forward. I'll share a little bit more about that. So being in a place where we were already thinking about and reflecting on what the role is for the Empire Health Foundation and in many ways for philanthropy as we think about health and equities across our systems, and then overlaying that with the pandemic that we've all been faced with. It's been an interesting time, some ways an opportune time to really do that reflection and really lean into where we're headed. And I'm excited to talk more with you all about that as we move forward.
Awesome. Thanks, Zeke. Appreciate it. Yeah, looking forward to that. And Senator Randall, you're batting cleanup here. You'll bring us home before the dialogue. Welcome, and thanks for your public service. And we'll kick it to you for some introductions. Oh, there you go.
I double clicked. Thank you, Bill. And it's so great to join you and Zeke and you, Kaimi, for this conversation. It's is, I don't know, my second or third time joining the State of Reform, and it's such a great, conference to really dig in and think about innovating in healthcare solutions and how we can work better to keep our communities healthier. I'm Senator Emily Randall. I represent the 26th Legislative District, which is west of Seattle on the Kitsap Peninsula. My district includes Bremerton, Port Orchard, Gig Harbor, and the Key Peninsula. And I've been in office for 3 legislative sessions so far. But before I joined the Senate, I worked at a number of healthcare organizations, raising money to close gaps in care needs for families and LGBTQ communities across the country. I worked at Children's Hospital Boston and San Francisco AIDS Foundation and Planned Parenthood, making sure that our neighbors could be connected to care. And I realized at one point that I could not raise enough millions of dollars to fix all of the gaps I was seeing in the system. We really needed the state to step up and strengthen those safety nets and ensure that folks are connected without having to rely on philanthropy, which I, as a former philanthropy professional, really feel that it's an important partner. But, sometimes the winds change and we shift our philanthropic priorities, and sometimes that leaves populations behind. So in the legislature, I've, brought some of that professional experience and also my personal family experience. I come from a family with a younger sister who was born with complex disabilities and whose life was changed because of Medicaid expansion in 1993, when our family got to trust that Olivia's care would be covered by Medicaid. Her, important medical equipment, her specialist appointments. And that really was the difference for us. I also come from a Latinx family and saw some members of my family face different health barriers, face different treatment at the doctor, face different barriers to accessing the either appointments or the pharmaceuticals that they needed to take care of themselves. And I saw that not only within my family, but within my community and further, when I was working in the healthcare space. So I guess reflecting on COVID and how this pandemic has shown a spotlight on inequities that have not just been here for a while, but been in our healthcare system since we have had a healthcare system. Since our country was founded, we have had these not just barriers, but denials of care and coverage and mistreatment of some members of our communities of color in our country. And we know this even more, now that we've lived through this last year and a half. Amy mentioned the Marshallese population in Spokane being so intensely, disproportionately impacted by COVID infections. Similarly, in the Hispanic community, which is 13% of Washington State's population, we saw upwards of 44% infection rates. And we could rattle off as many, COVID-19 statistics. Even before COVID, we saw maternal mortality rates for Black and Indigenous communities be so dramatically higher. Black women 4 times more likely than white women to die of pregnancy-related complications. We see disproportionalities in who can afford to take time off work when they're sick in order to safely quarantine or care for themselves or deal with a family member's health complication. And disproportionalities in who can afford prompt medical care at all, who has coverage. 6.2% of Washingtonians who were uninsured as of, or 6.2% of Washingtonians were uninsured in 2018. And the highest majority is Black and Hispanic and American Indian communities who are unable to be connected to coverage. And we all know that when you wait until you can go to the emergency room for care, you're not going to have the best health outcomes, and it's more expensive for our whole system. And, bringing dental into it, which we don't always think of in comprehensive healthcare, only 20% of Medicaid eligible Washingtonians saw a dentist in the last year. Only 20%. And that means that folks who are already struggling, who are low income because they're Medicaid eligible, are deferring care or delaying care and are going to be unhealthier in the long term. So really understanding these impacts and then figuring out how we translate them into community-led policy reform. It was great to hear you all kind of talk about that important element in changing policy, because we can't just come up with ideas of what we think are going to be best for our neighbors in this community or that community. We really need to work alongside them and to let folks who are impacted drive those policy changes. So that's why I've been so excited to work on the creation of health equity zones, establishing our Universal Healthcare Commission, expanding postpartum Medicaid coverage, and so many other policies, because they're really driven by community.
That's awesome. Thanks for sharing some of that. It's so cool to listen to all three of you and just hear the passion that you all have for this topic as well. And it's not just a job, right, or a part of your role. It's something you really believe in, and that's super cool. We've got some things that we talked about sort of prior to coming on in terms of some of the learnings, but we do have a couple of questions in the chat. So if the panel's okay, maybe we'll start with those and then come back to some of the things that we had talked about during some of our prep time. One of the questions, if I can do this correctly and bear with me, Sulani Madsen asks, broad statewide mandates remove the ability of communities to address local conditions. It also undercut credibility of public health institutions. How do we restore confidence in the public health system before the next crisis? Anyone want to take that?
Well, I'll jump in and start. I'm not sure if this is going to answer Sulani's question or concern specifically, but one of, I think the really important pieces of Senate Bill 5052, which was Senator Kaiser's health equity zone policy, is that we have expertise within the community, and community members can and should work together to identify public health disparities and to work to solve them. And so these health equity zones are partnership between local public health as well as community organizations and medical providers to identify, folks can self-identify that they're equity zone, but there's also some metrics to identify health equity zones. And that's where there can be collaboration in community for coming up with solutions to public health problems. I think that they're just kind of my personal thought addendum to battling a statewide pandemic, a global pandemic, is that there are times when we need a statewide solution to a problem, when we need to make sure that everyone across our state knows that we are part of the team and we are responsible for slowing the spread of COVID-19, for example. And so I certainly support that collective action when we need to take that collective action. But I do think there are definitely times when community-based solutions will drive us to success.
Bill, if I could just pick up from there quickly. Senator Randall, thank you for your service and your work at the state level and in communities. Really appreciate the work you've done and the promise of what that means moving forward. Sulani, appreciate having you on the call and for the kicking us off with such a significant question. There's two thoughts that occurred to me in response to the question. One is I think, this idea of how we really activate and support our local communities to have, to be in a position and to have the agency to really address issues that are occurring in their communities is really, really important. And it's at the center of, I think, this health equity zones conversation. It's at the center of, frankly, how we're going to address or tackle health inequities in a significant way. And that, I think, is an important context geographically. It's also important when we think about cultural communities in our state. And so, I think there's a broader question that is not in the context of just the pandemic about what it looks like to really ensure that communities that our systems are designed to really support community-led solutions, as Senator Randall was talking about before, and as I believe that Kaimi's work is a lot about surfacing what that looks like to do that in an effective way, how it's culturally appropriate, and how it's really designed to support those communities. So that I think is a broader question, but an important one that you're raising. I think in the context of the pandemic and the reality of the ways that our solutions, our public health solutions to this pandemic, are running right in the face of the reality of the ways that people think about how they want to take care of themselves and how they want to take care of their communities is a big challenge. And on the one hand, I agree wholeheartedly with Senator Randall that facing what is really a global pandemic and a global issue and challenge, it is important for our institutions at all levels to really take a role in supporting what effective public health looks like. And I think that the state has a real responsibility to do that in this space and at this time. And I think it's important for all of us to recognize the way that plays out is different in different spaces and places. And if a statewide mandate around vaccinations for healthcare workers means that potentially we've got hospitals in rural communities that won't be able to meet their local services, won't be able to be a part of the public health solution that's required, it puts us in a real challenge. I'm not suggesting that the state mandate isn't appropriate, but I do think it means we have to think about Newport Hospital in Pend Oreille County differently than we think about Children's Hospital in Seattle in terms of the impacts and the implications of what those decisions are. And then I think actually we do have a responsibility as local communities to try to wrap ourselves around that and say, okay, what do we do to really support the kind of public health outcomes that ultimately we want? In the context of the political stratification that we see ourselves in at this moment, that's really, really tough to do. And there's definitely a role for the state and there's a role for local communities in how we get through this.
Yeah, thanks, Zeke. I'm going to jump to another question here. And Kaimi, I'll start with you because I think you might have a really great perspective on this. And that comes from Jessica Williams, who asks, what are your thoughts on people deferring care due to the pandemic? Are there certain communities where this is a prominent issue? And before, Kaimi, you jump in with a response or reaction to that, it's a great question. It's actually a question that's going to be tackled later on today during another panel, I think at 1:30. And it's specifically addressing that question. So Jessica, you may want to pop into that panel as well at 1:30. But Kaimi, any response to Jessica's question?
Sure. Yes. We absolutely saw people deferring care, not only because their providers' offices were closed for a while at the beginning of the pandemic, and people, figuring out what they're going to do to be able to see people to provide care. But people, for telehealth visits, not everybody has the ability or the what they need to be able to join a telehealth visit with their provider. And as Senator Randall pointed out, not everybody has healthcare anyway. And people weren't even able to go to the emergency room and still aren't in some places in this country because of the pandemic and, beliefs about getting a vaccine, the vaccine hesitancy, and other information out there that is, impeding people's decision to get the vaccine and wear a mask and, help stop or slow the pandemic, the spread of the pandemic, COVID-19. But absolutely, there have been, people, we see that hypertension management has gotten worse during the pandemic. People are sitting around, at home, not going out and exercising and eating. I know I sat here on Zoom calls all day long and ate way more than I should and didn't get out. So I think a lot of our health conditions have gotten worse during the pandemic. And I think more and more people are starting to get out now that people have been, some people have been vaccinated, and we know wearing masks can help. So some people are returning to the gym, in safe ways and And so organizations and companies are putting policies and guidelines in place to help protect people and mitigate the spread of COVID-19. So I absolutely think that it did affect care, people's access to care, and hopefully, communities are able to get to their providers now more easily, especially here in Washington, because we're doing a good job, I think, of mitigating the spread of COVID-19. But giving people more access to the internet and to smartphones and computers and the things that they need to access a telehealth visit when they need one.
Yeah, thanks, Cami. And I guess from our perspective, what we see is, and Shayla Holcomb, just to through this kind of a comment and question in the chat, the stretch on our healthcare workers as well has been really significant. We've seen that firsthand, where nurses, physicians, office staff members are just incredibly stretched trying to manage patients, and it's a lot of it's from the decisions to defer healthcare, people coming back or trying to find ways to be cared for through telehealth. It's been really hard on our healthcare workers, and so I do think, and Shayla, to your question, what conversations and initiatives are coming across about building resiliency across our healthcare workforce. Any comments around that?
I also think about the technology equity, and providing communities with more access to the technologies and the internet access that they need. I know I've been out at Colville in the past, and you had to go stand up on a hill to get a cell signal with a certain provider. Other than that, you can't even get a signal. So,
no, it's absolutely true.
Yeah, and I will say we were facing a nursing and healthcare provider shortage before we were struck by this pandemic, and we were working, to create solutions to build that pipeline and also build resiliency among, the providers that we have. And I'll also call out, since the topic of our conversation is these disparities, that there is a big gap in representation, especially as you get to providers with more education requirements. With a larger scope of practice, we see fewer and fewer of our community members, of communities of color, represented among the provider population. So, we've been doing some work. We funded a Latinx physician workforce study, and then had some policy that came out of that to try and increase goals of admission into our medical schools. I'm reminded that until only a couple of years ago, nurses weren't even guaranteed a bathroom break or a meal break on the job. And so we worked to pass meals and rest breaks for nurses. Obviously, in a crisis situation, things are different, but ensuring that our nurses, our frontline care providers in situations like this, have the tools that they need. I'm also exploring as chair of higher education and workforce development, along with my counterpart in the House, Representative Vandana Slatter, exploring some graduate school tuition reimbursement or financial aid options, because we know that's not only a barrier to increase our diversity in our workforce, but it also leads to burnout and job dissatisfaction if you are struggling under mountains of debt. We did establish some really exciting financial aid with the Workforce Education Investment Act, ensuring that low-income families have access to that financial aid, but there's more to do. And some other creative solutions are building apprenticeships that will allow more folks to enter into different levels of care in the workforce to make sure that our community is better represented and that we have a robust and resilient workforce.
If I could, 3 quick thoughts to build on what other folks have been talking about here, all of which are about, one, I think recognizing that our healthcare system and the ways in which we over-rely on highly educated individuals in the system both exacerbate that problem that Senator Randall was talking about in terms of who our healthcare workers are, and what communities they represent and where they come from, because it takes a while to get a doctor's degree and to be in a position to really serve community. And also, the kind of rigidity of that system gets in the way of some of the other things we've talked about. So three ways that three things that came to mind for me about ways people are trying to address that. One, we partner with an organization, Spokane Teaching Health Clinic here in the region, that supports graduate medical education for docs across multiple different specialties in the area. And one of the kind of newer developments there is that those residents, as they're in their programs and as they're engaging with each other, are really beginning to identify the needs that they have in terms of their own self-care as they work through the system. And that I think years ago would have been not a conversation that was allowed. But at this point, I think there is a beginning of a recognition that we really have to Senator Randall's point, really create a space where healthcare workers have the ability to take care of themselves, not just in really simple ways like having a bathroom break, which that makes a lot of sense, but also in kind of broader ways around the kind of mental health supports that are required and trauma-informed approaches to acknowledging the environments that these healthcare workers work in. Second one is that specifically, as we've worked with Washington State in supporting the Center for Native American Health and the ability for Native American students to become doctors, nurses, pharmacists, the recognition that all of the challenges that the system presents for healthcare workforce professionals are exacerbated for individuals of color who are entering a field where they don't see many other folks that look like them, where they may or may not be able to serve in communities that they really want to, and where that cultural identity that they bring to the table is really, it has been in many ways, they've been asked to kind of put that to the side and be a healthcare professional and whatever that means. So part of what the center at Washington State is about is really trying to cultivate and create a space where we recognize that there's value in people being able to bring their identity to the table, whether that's cultural, whether that's about their gender, whether that's about their sexual orientation, and that there needs to be a way in which we allow for those peers to really support each other in building their ability to be both a professional and have these other identities at the same time. And that it gets at this notion of resiliency that Shayla was talking about, is how do we build resiliency for those individuals in that space? And then the third piece that I would say is also the recognition that particularly as we talk about how we meet the needs of individuals and families in communities where health inequities are most significant, we know this is not a question anymore. We know that people who have lived experience, who have shared in many ways the struggles that those individuals and families have and how to access and get effective care in the health system are the people who are best suited to actually meet those individuals where they are and help them navigate these systems that really aren't designed for them effectively. And yet we don't have a system yet that has really created the space for that type of professional experience to be fully incorporated into the system. So in the course of the pandemic, we've seen that those are the individuals that met tribal elders on the front end of this to help get them vaccinated, to help to check in on them and see whether they're doing okay at home and what additional supports they need. We know that these are the same individuals that act as really important community navigators that shape the way that more broadly that people are willing to engage in public health solutions that both support them and their families, but also support their communities. So I think as we move forward, part of the question for us, and I know that the legislature has been working on this in some ways, is not how we necessarily professionalize those positions, but actually how we create space for the recognition that lived experience and that understanding what it means to navigate a system that isn't built for you and to be able to advocate for yourself in that process are fundamental to how we meet people's needs, and that those challenges, that those patients and individuals face are the same ones that burn people out, as they are not really well equipped to be able to support those individuals to get to success in the existing system.
Yeah, and the impact of the patients is just the loss of education, especially around the value of their healthcare. I think that's the piece that, again, we've seen this stretch on our healthcare workforce takes that education away. And so just, again, to the point about even the dental care, like do patients truly value the importance of healthcare and educating around that? And so, with a healthcare workforce that's stretched like they are, that can be impacted greatly. We talked a little bit about telehealth. I think telehealth is probably here to stay in some form, regardless of when we sort of come out of the pandemic. But Kaimi, to your point, it's not easy across many parts of the state of Washington. And so Calais asked a question about, what are we doing to sort of improve the telehealth experience or capability, especially in some of the areas that we've been talking about here. And so, Senator Randall, maybe I could punt that one to you. Do you have any thoughts around that in Clay's question?
Yeah, telehealth was definitely a big topic of conversation in this past legislative session. And I know, many of us were using accessing telehealth appointments in addition to, our constituents. And one thing that we did was provide some emergency authorization around licensing and billing to allow some of those relationships to be a little smoother. But another piece that didn't come before the healthcare committee that was hugely important was our investments in authorization for more broadband expansion. I think it was Kaimi's point about, where you stand to access an appointment with a provider if you have no cell signal. We have huge disparities in our access to broadband in our state. We have them in urban areas and we have them in rural areas. We have them, particularly on tribal reservations and communities that are disconnected to so much care. And we need to do better. We all, I think, this past year have recognized that broadband is infrastructure the same way that access to running water and power is. If your kids need to learn remotely, or if you need to access a medical provider when you can't drive there, or it's not safe for you to go into a facility. And so we passed a policy that allows municipal governments to enter into retail broadband relationships. Again, not necessarily a healthcare bill on the surface, but one that is going to provide access to so many more communities, not with a flip of a switch, but over time, we can build up our broadband infrastructure. We also passed another not so sexy bill that's called Dig Once, so that when the Department of Transportation is doing projects where they're digging up the road, if we can lay broadband or fiber or provide access to do that later without having to dig it up again, that's something that we're doing. Those are really important to the connectivity of our communities, and will continue to allow folks to increase the ways that they can connect with their providers.
Awesome. Looking at the clock, we have a couple of minutes left, and I promised as the moderator that I wouldn't allow us to go too far over. And it does look like we've addressed the questions in the chat. So maybe some parting comments from the panel in terms of some of next steps, thoughts, things that you want to leave the audience with before we close it out. Kaimi, can we start with you?
Sure. And in looking at some of the comments, questions in the chat section, yes, we absolutely need people with, specialized care experience and expertise. But I think too, we haven't leveraged, and I think Zeke brought this up about health navigators, supporting and training of community health workers. And, American Indian communities, Latino communities have a long history of community health workers and promotoras who, can be trained to provide some of the, the kind of prevention and secondary care that needs to happen in communities, so that we don't have to rely on people going into the doctor all the time, into the clinic, or even accessing telehealth for every single thing. So I think support and training for more community health workers in the state would really help, and reimbursement for their services. Thank you.
Thanks, Kaimi. Zeke, how about you?
Yeah, thanks, Bill. I think the pandemic has required us at multiple levels to make rapid and adaptive change to be able to address the needs of communities, population that we work with. You see that in the healthcare system. If we think back, it feels like it was a while ago now, but if we think back to that point where the system was almost completely shut down, and we really had to pivot to telehealth in a way that there had been all kinds of barriers to that in the past that were removed because of the urgency of the moment. From in an education space, asking if you would have asked schools to provide online education as the only way that they can meet the needs of kids before the pandemic, people would have laughed you out of the room. And so I think on one level, the pandemic also taught us that we really can actually pivot and adapt when it's really required and when there's an urgency. And when I think about all the ways in which health inequities have been here in our community, in our system for a long time, and hasn't really represented enough urgency for the system and for institutions like mine and others to make the change that's required. I hope that part of what we take from this pandemic is we actually can make those changes when we desire it and when we have a sense of urgency to do it. And there's a lot more that we have to do to be able to accomplish what we want around health equity in our communities.
Thanks, Zeke. Senator Randall.
Yeah, thank you. What a great conversation. And I love hearing all the perspectives that we have and the incredible work that's happening on the ground to think about new solutions. And I'm right there with you, Zeke, thinking about how particularly disability communities have been asking for more access to remote learning, to remote work options, and have been told over and over and over that our system just can't adapt to meet those needs. And when all of us needed to do that, all of a sudden we were able to. And so yes to learning those lessons about access. And Kaimi, you mentioned, Native-based health navigators and promotores in our community. I just want to lift up the Native dental health therapy model that has been working so well on tribal lands in Washington state and in Alaska. And we have the opportunity to extend that model to statewide to ensure that there are dental health organizers and dental health therapists coming into schools, meeting elders in their homes, understanding the challenges that are facing our communities. And so that's one policy that I'm excited to work on this year, definitely inspired by lessons learned from the pandemic and access needs and how we can solve those problems with tools that have already been working in BIPOC communities for years before.
Awesome. Well, just to wrap it up, first of all, I want to thank the panel. So many great learnings coming from just listening to each one of you. So I appreciate that. Thanks to everybody who joined. Thanks for the questions. It really gave us a chance to really dig in on some of our experiences and some of our thoughts. And I guess what I would say in closing is what really jumps out at me around this topic is it needs to be a joint effort. Like if we're all working just independently, I don't know that we can get it where we need to. So please, if you have additional thoughts, ideas, questions, I know my contact information is on somewhere in this meeting. DJ did a nice job of setting us up and making sure that we included that. So please, please reach out with any thoughts that you might have. I know at Genentech, we would love to be able to partner in any way that we can to help support this work. And I plan to, take this forward and work with not only my panelists, but hopefully many of you. So thanks again for joining and enjoy the rest of the conference. Take care.
Thank you.
Thanks.